So now we are moving back up to the proximal humeral fractures. This is a rather recent literature review of the papers dealing with proximal humeral fractures, and it came out 2008. And the conclusion was rather disappointing. They said that current studies lack, randomization, comparators, and were actually, it was not possible to give any clinical recommendations. And if you put these together, you can see that does it really matter what we're doing? If you look at the confidence interval and the mean values of constant score, you see functional rehab after proximal humeral fractures. This is the results. And then if you have plate fixation in all these papers, the yellow is the average of all those papers. And then you have nailing, this yellow, and then you have percutaneous fixation. And then maybe hemiarthroplasty down here is worse. So you may say, well, it's all around this line. But the truth is, of course, if you really analyze these papers, they're dealing with completely different type of fractures. So this type of a comparison is not really of any value. So what are we dealing with? We really have to look at this at different subsets of fractures. It's about 4% of all fractures. So it's a big group of patients. And more than half of the patients occur in the elderly, over 70. But there are also a lot of young patients suffering from this fracture. And the incidence is increasing, so we really have to have some knowledge regarding these fractures and the treatment in our daily practice. And there is a lot of evidence that minimally displaced fractures can be treated conservatively. So that's sure. And in our unit at St. Göran's, we operate about 25% of these fractures. So 1 out of 4 is going into surgery. And if you look at the type of fracture we can deal with, this is from Codman, and you look at the lesser tuberosity, greater tuberosity, head fragment, and shaft as possible fragments, you have 12 different type of fracture pattern. And this is what Ralph Hertel did with the Lego blocks, and you see these. And if you look at the more complex fracture, that is 3- and 4-part fracture, there are 6 different patterns. And I will focus on the more complex fractures because that's where there is a lot of controversy. So we were asked to bring an example. So this is a typical case that you may have in the emergency room. 69 years old male, very active, and he comes in with this fracture. So what is the best evidence today to deal with that? Well, first we are talking about classifications. And the problem with the classification of the proximal humeral fractures, with all the systems available, is that there is a poor inter- and inter-observed reliability, meaning we don't agree. If you say, what type of fractures do you have? So we have different opinions. And you may say, well, do a CT scan, that probably improves it. Well, actually it does not. Unless there is a very complex 4-part fracture, then there is a more agreement if you have a CT scan. But there is a consensus that a CT scan adds important information for you as a surgeon when it comes to planning and executing the procedure. And the most widely used classification, I think it's the best evidence today to use, is the nearest 4-part fracture because it's easy, you can all remember it, and when you talk to the young surgeon in the emergency room, you know what you're talking about. And nearest 4-fragment concept is to have the 4 fragments, possible fragments, the head, the 2 tuberosities, and the shaft. And in order for it to be a separate fragment, it has to be displaced, a centimeter or rotated, meaning that this is a 1-part fracture because there is no displacement between the 4 parts. And this is a true 4-part fracture. But as we heard from the cervical hip fractures, you don't base your treatment only on the classification. And the reason, of course, you are dealing with different type of patients. The X-ray is just one thing. And you have to look at age of the patient, the functional demand, what does the patient want to be able to do, comorbidities and the bone quality, other injuries, of course, and your own experience. What can you do? And you see this old patient have different functional demand than this old guy, or this young patient skier. They may have the same fracture. So you have to individualize treatment. And then it comes to vascularity. We heard that if the head is dead, there is no vessels to it, you should always replace it. So what is the evidence? Well, we know that there is strong support that a 4-part fracture has a high risk for avascular necrosis, particularly if this medial hinge is disrupted or if the metaphyseal extension is less than 8 millimeter. But does it matter? Well, there is evidence now that an ischemic head can revascularize without collapse. And this is a study looking at a prospective study with MRI, and out of 51 patients, 10 had an ischemic head. And at 5 years follow-up, only 2 had collapsed. So preservation of an ischemic head is worth considering. So an avascular head does not mean replacement today. So let's focus now on 3- and 4-part fracture with this background. This is a review of all the literature up to 2001. And they looked particularly at 3- and 4-part fractures. And there were 147 reports, but only 24 met reasonable quality. But the conclusions were that there were evidence that the conservative treated patient had more pain and worse function. But there was no clear difference between arthroplasty and fixation. And the problem occurs with this systematic review, as Tiedemark said, that there are different types of methods involved, and some of them are outdated, so it makes it difficult to compare different fixation techniques. But if you look at today, what is the evidence for implant selection? Well, there is no question, I think, today, based on the literature, that the locked plating has the best chance of achieving anatomical reduction and stable fixation of the proximal humeral fractures. Intramedullary nailing is favored by some, but it is inferior to lock plating in the more complex 3- and 4-part fracture, as well as the percutaneous pinning. So today, 2010, the evidence is for lock plating if you use fixation. And what can you achieve now when we're talking about should we fix it or should we replace it in these difficult fractures? So what is the evidence? If you look at the locked plating, there are some series now with case series and case control series, and this included 12 series, almost 800 patients, and the mean constant score was 74, slightly lower in 4-part compared to 3-part, but a fairly high revision rates. And if you fix them, what should you avoid? Well, there is a strong support in the literature that you should avoid varus deformity, plate placed too high, or greater tuberosity malunion. All those are factors that have a negative impact on outcome, as well as old age, if, of course, you cannot change that when you have a patient. So what is that compared to the other option? That would be arthroplasty. If you look at arthroplasty, and this is a recent review of over 800 patients, the constant score was mean 57, about the same level of complications as for plating, but the lower constant score. And if you look at the subjective evaluation, there was only 7 papers where actually the investigator have asked the patients, are you satisfied or not? And 42 said, I'm not satisfied. They were unsatisfied. So a fairly high number of patients were not very happy with the hemiarthroplasty. And the key is tuberosity healing. If you have a malunion, then you have a worse outcome. This is what you want to have, the tuberosity healed in an anatomical position. Old age is also a poor factor. So plating in hemiarthroplasty does have a worse outcome in elderly patients compared to what you would like to see compared to young patients. So what is there? Is there another option? Well, recently you have the reverse arthroplasty that has come on board as a clinical tool in complex fractures in the elderly, because it seems like plating in hemiarthroplasty does not work as you would like in the elderly. There is not too much evidence yet out on the reverse arthroplasty for fractures. There is only 4 case series published, level 4 evidence, 4-part fracture in the elderly. There's 98 cases altogether, and a constant score of 53 in these 4 series. So if you summarize this now, it seemed to, in the literature that 3- and 4-part fracture should be operated. But what should you do? Well, first of all, you have to choose treatment depending on not only fracture type, but what kind of patients you're dealing with. And there is evidence, even though it's level 4, that it's probably better to operate on these fractures than to leave them alone. And CT does not improve the classification, but it helps the surgeon to execute the surgery. And ischemic head can revascularize, so it may be worth preserving. And the best internal fixation method today, according to the literature, is lock plating. And you should avoid varus if you fix them. And of course, in an old patient, you may consider something else. And if you're doing hemiarthroplasty, try to avoid tuberosity malunion. I think the reverse arthroplasty will play a bigger role in the future. The results are promising, but we need more evidence for the true indications for using that. So my personal interpretation of the present evidence in 3- and 4-part fracture is, of course, that you have to individualize. You have to look at the patients. Even an 80 years old may live a very active life or may be institutionalized. I think plain X-ray and CT scan should be done in order to really evaluate the fracture, and we should try to operate within 3 to 4 days. And if restoration of function is the goal, if you have a patient that want to have the function back, the best method today is to do an anatomic reduction and fix it with a lock plate, regardless of the vascularity of the head. If the patient is younger, I would say maybe around 75. The true age limit is difficult to say, but for me, somewhere around that. If I can't fix it, if I cannot do a good fixation with the plate, I think hemiarthroplasty is the true method you should switch to. The problem in the elderly, the evidence today that the results of both fixation and hemiarthroplasty is very unpredictable in older patients. Hemiarthroplasty is probably slightly better than plate in this age group because they usually get good pain relief, but maybe poor function. If you do a fixation with a plate, there is a high risk you will have screw penetration, secondary displacement, and pain. So it's safer than to use an hemi in that older patient. Then, of course, reverse arthroplasty in some centers are now routinely used, but we need more studies to really define that. And of course, the surgery is more difficult. There is a learning curve and other types of complications, but that is more into the future. So the case we saw, what did we do? Well, we do plate fixation because it's active, 69 years. You try to reconstruct the head and the greater tuberosity. Thank you.